Today we will learn median nerve. It is the main nerve of forearm and it is also known as labral nerve as it regulates the coarse movement of hand. Its root value is C5 to T1. Its origin, it originates from two roots, that is the lateral root and the medial root. Lateral root arises from lateral cord and medial root arises from the medial cord. Now these two roots unite to form median nerve. Now coming to course of the median nerve. Median nerve in arm, median nerve in forearm, median nerve in hand. In arm, it starts its journey from axilla and runs in between biceps brachii and the brachialis muscle. Then it is related to the brachial artery. Median nerve is lateral to the brachial artery. Suppose this is the brachial artery. Median nerve is lateral to the brachial artery. Then at the level of insertion of coracobrachialis muscle, it comes anterior to the brachial artery and below it becomes medial. This is our median nerve. Median nerve above the insertion of coracobrachialis, it is lateral. At the level of insertion of coracobrachialis, it is anterior to the brachial artery and below it is medial. Now it maintains its position till the cubital fossa. Okay. Now in cubital fossa, we all know from medial to lateral, it is amphibious, that is the median nerve, brachial artery, bicipital aponeurosis and the superficial radial nerve. So this is our median nerve. Now it passes in between the two head of the pronator teres, humero-ulnar head and the radial head of the pronator teres. Now it passes in between the flexor ditorum superficialis and flexor ditorum profundus. But it is adherent to the flexor ditorum superficialis. The inner deeper aspect or inner aspect of the flexor ditorum superficialis, it is adherent. Okay. Now at the level of proximal 1/3 and the middle 1/3 of the forearm, it gives one branch, motor branch, that is called anterior interosseous nerve. Now this become superficial, just 5 centimeter above. It becomes superficial and comes in between the flexor carpi radialis laterally and the palmaris longus medially, where it is more prone for injury by the suicidal cut or the available for the anesthesia of the median nerve. Now the 3 centimeter proximal to the wrist joint, it gives one branch, that is the palmar cutaneous branch. Palmar cutaneous branch of the median nerve will supply the skin over the thenar eminence and the center of the palm. Okay. Now it passes deep to the flexor retinaculum. This is flexor retinaculum and it passes deep to it. Now it gives motor as well as the cutaneous branch. It gives cutaneous, or you can say sensory, for lateral 2/3 of palm plus lateral 3.5 of finger plus lateral 3.5 dorsal aspect nail bed. This is the cutaneous supply in the hand. And what about motor? Is supply flexor digitorum, flexor pollicis brevis, only superficial one, flexor pollicis brevis, abductor pollicis brevis, and opponens pollicis, as well as the first and second lumbricals. These are the motor supply of the median nerve. Okay. This is the course. Now, some branches I have already told that it gives no branch in the arm, only gives few branch to the brachial artery. Now, in the forearm, in the cubital fossa, this is the cubital fossa. At this level, it gives all the supply all the superficial muscle, that is the pronator teres when it crosses in between the two head, as well as is supply palmaris longus, flexor digitorum superficialis, and the flexor carpi radialis. Now it gives anterior interosseous, which supply the deep muscles. It runs anterior to the interosseous membrane and supply flexor pollicis longus, the other deep muscle pronator quadratus, and the lateral half of the flexor digitorum profundus. These are supplied by the anterior interosseous nerve. Okay, and I have already told these branches. So these are the branches. Now coming to the function. Here at the region of the cubital fossa is supply the flexor of the forearm, all the superficial flexor of the forearm. First pronator teres. So pronation of the forearm will be lost. If there is injury at the cubital fossa, pronation of the forearm will be lost. Now come to flexor digitorum superficialis. What it does? It passes up to the middle phalanx of the supply the flexor digitorum superficialis, which is going to middle phalanx of the lateral the flexor. There is only one tendon is going to the flexor pollicis longus in the thumb, but rest of the finger is supplied by flexor digitorum superficialis and the flexor digitorum profundus. Superficialis only up to the middle finger and the profundus up to the distal finger. So the proximal interphalangeal joint, metacarpophalangeal joint, and the wrist joint, all these at this level, the flexor will be lost due to the affection of the flexor digitorum superficialis. Now, coming to the flexor carpi radialis, what it does? It helps in the flexion of the wrist joint along with the flexor carpi ulnaris. So, if person attempt flexion at the wrist joint, as flexion is done by both flexor carpi radialis and ulnaris, but radialis is paralyzed. So, if a person attempts flexion at this joint, there will be ulnar deviation. Now, what next? The flexor the superficial, or then palmaris longus. The palmaris longus will not be supplied. There will be, it does, it only passes from there and form palmar aponeurosis. So there will be somewhat, there will be also it does flexion of the wrist joint. So there will be weakness of the flexion. Why weakness? Why not? There is loss of flexion because the flexor carpi ulnaris and the medial half of the flexor deuterum profundus is escaped, are escaped. Okay. Now coming to the anterior intraosseous nerve, if injury at this level, as the anterior intraosseous nerve will be involved, then the motor supply, as it is a pure motor nerve, all the deep muscles will be paralyzed, due to which there will be OK sign. There will be no OK sign will occur. No OK sign. To perform an OK sign, the flexion of the index finger and the flexion of thumb required. Just like this. Flexion of thumb at the superficial, at the proximal interphalangeal joint and the proximal interphalangeal joint of the index finger should be required. But both will get paralyzed, so OK sign will not be possible due to the affection of the flexor pollicis longus and the lateral half of the flexor digitorum profundus, as well as there will be no pointing index. There will be pointing index, as there will be no flexion at the distal interphalangeal joint and the proximal interphalangeal joint. These are not possible in the index finger, so there will be pointing index sign. Also, there will be, but why not with the, as we have read that the lateral half of the flexor deuterum profundus is involved due to the median nerve, but the middle finger will escape due to the quadriga phenomena. In quadriga phenomena, there is a communication between the flexor deuterum profundus of middle finger and the ring finger. There is a communication in between. So if this one, the medial half of the flexor deuterum profundus is patent, it will supply also the flexor deuterum profundus of middle finger. So what will be the resultant? Only the flexor deuterum profundus of index finger will lose. So there will be pointing index. Now there is a carpal tunnel syndrome in which there is a compression at the carpal tunnel, because it is through the carpal tunnel the 9 tendon passes, that is the 4 tendon of flexor deuterum superficialis, 4 tendon of flexor deuterum profundus and the flexor pollicis longus tendon. They all get compressed, and above all there is median nerve. So median nerve will be compressed, so there will be sensory loss over the lateral 2/3 of the palm and the lateral 2/3 of the palm and the lateral 3.5 of finger. But only remarkable point is that the 3 centimeter proximal to that palmar cutaneous branch of the median nerve arises. It escapes from compression, as it gives sensory supply over the skin over the thenar eminence, but it is also lost, as well as it supply the center of the palm. So sensation over the center of palm will be present due to the escape of palmar cutaneous branch of the median nerve. Okay, so we have read if there is injury in the arm, if there is injury in the forearm level, and if there is injury in the wrist level. There are many syndrome which is associated with the median nerve, and they are no okay, just shake hand and escape. This is a mnemonic. No okay. That I have said earlier, there will be no okay sign. Just shake hand. That hand of benediction. Hand of benediction or preacher's hand. Like this, जैसे कोई आशीर्वाद देता है तो ऐसे. Like only this much is flexed. The index finger. This is called hand of benediction. ऐसे इस तरीके से. So, as the lateral half of the flexor deuteronum profundus is involved, so there will be hand of benediction or preacher's hand. Just escape. There are two E, and in the middle there is SCAP. SCAP. There are two things from each. That is supracondylar fracture. Supracondylar fracture is very common, which occurs at the region of supracondylar. Supracondylar fracture of humerus. When at the region of the supracondyle, above this two medial and the lateral epicondyle, when fracture occur at this level, there will be injury of the median nerve as well as the brachial artery. So all the symptoms, because all the branches arises just after that, so all the functions will be lost. That is the flexion of the wrist joint, the weakness, and there will be atrophy of the thenar muscles. There will be anesthesia in the lateral 2/3 of the palm and the lateral 3.5 of the finger, and all those deformities. So supracondylar fracture, and then also there is suicidal cut, because here it becomes superficial, proximal to the carpal tunnel, and liable to injury by the suicidal cut when it runs in between the flexor carpi radialis and the palmaris longus, as well as the Struder syndrome. As for Struder syndrome, there is one ligament of Struder which is supposed to be the third head of the coracobrachialis muscle, lies in between the medial epicondyle and the supratrochlear spur, which is situated 5 cm proximal to the elbow joint. There is supratrochlear spur, and in between these two there is a fibrous structure which is called ligament of Struder and supposed to be third head of coracobrachialis. It is present in only 1% of the cases, but when present, it compresses the median nerve. And C for carpal tunnel, only once is there, the carpal tunnel syndrome. We have already read that all the muscles which are supplied by after that, they are the first lumbrical, second lumbrical, they will be paralyzed, and the thenar muscle atrophy will be there. There will be flexion will not be lost, because only the superficial head of the flexor pollicis brevis is suffered. Deep head is supplied by the ulnar nerve. So abduction as well as the opposition of the thumb will be affected, and this will result into the ape thumb deformity, because adductor pollicis escaped. Adductor pollicis will escape, which will lead to the adducted thumb. This is A for ape thumb deformity. And 1A is for anterior intraosseous nerve syndrome. Anterior intraosseous nerve syndrome, when anterior intraosseous nerve get entrapped by somehow, either by the pronator teres, when there will be pronator teres syndrome, there it will also affect it, or by separate method in which only anterior intraosseous nerve will get affected. This will lead to the what will be that method? There is Ganser muscle, which is the additional head of flexor pollicis longus. There's flexor pollicis longus, and there is one additional origin of flexor pollicis longus, which passes like here, just above the anterior intraosseous nerve, and it is present in 68% of cases. So this is a common variation that the Ganser muscle is present. GANTZER, Ganser muscle, and it compresses the anterior intraosseous nerve, which affect the flexor pollicis longus, pronator quadratus, and the lateral half of the flexor digitorum profundus. So no okay sign will be there. There will be hand of benediction. Okay, and this is pronator teres syndrome. P for pronator teres syndrome, and 1P is for pointing index. So this is all about the applied anatomy of the median nerve. Thank you. As I have said earlier, the median nerve is the laborer nerve, and the laborer nerve which governs the coarse movement of the hand, and coarse movement of the hand is governed by the flexor muscles of the forearm, which is mainly supplied by the median nerve. So coarse movement of hand will be affected, as well as the fine senses, which is taken over by the cutaneous sensation of the index finger and the thumb finger. We can feel by this way only. So that's why median nerve is also known as eye of the hand. So this will get affected, as well as the thumb muscles. All the thumb muscles will affected. So there will be pincer grasp. Opponent's pollicis is affected, so pincer grasp is not done. Okay, and they are affected. And the preacher's hand, one thing I have declared that the preacher's hand, hand of Benedict, and this is and there is no flexion of the proximal interphalangeal joint and no flexion of the distal interphalangeal joint possible, because the flexor digitorum superficialis and profundus both are affected on both sides. But this is also supplied by the quadriga phenomena, so this can be flexed as there is a communication between these two fingers. So only this is there. And preacher hand, in the vague sense, it is said like this is the preacher's hand. Okay. So, and the sympathetic nerve, it is mainly carried by the median nerve. So trophic changes will be prominent in case of median nerve injury. Thank you.